We're starting musculoskeletal case review for the CK. As we go through this, we're going to talk about several important aspects of MSK for step 2. There are several big groupings of patient presentations. For example, patients that present with lower back pain. Lower back pain is a very wide differential that include things that are pretty benign, like a pulled muscle, that also include things that are very, a surgical emergency, like our cauda equina syndrome or conus medullaris impingement. So, having that wide differential is very important when it comes to these very sort of vague patient presentations. The other wide patient presentation that you need to have a nice differential for is when you have a pediatric patient that presents with a limp. Okay, kids that present with a limp, there's a wide differential there, a lot of different things we can talk about, and so we're going to start with that actually because, it's always a good place to start is talking with kids. So first case we have here, we have a 9-year-old boy referred to the pediatric physician due to a history of intermittent pain in his right hip. Okay, so right hip pain in a child, what are some of the first things that pop into your mind? Malignancy, yeah, we always need to have that eye for malignancy in kids. Great. So that's our differential. We're going to go from there. The pain began during a soccer game 6 months ago, has increased in severity over this time. Although he has tried activity restriction and crutches, the right hip continues to bother him, especially with any activity. He has no family history of similar complaints or disability. On physical exam, the patient is healthy, well-nourished boy at the 50th percentile for both height and weight for his age. He is afebrile, walks with an antalgic gait. There are no obvious deformities of either lower extremity. However, he has marked discomfort to palpation over the entire right hip region. Okay, with internal rotation and hip abduction cause significant pain. When compared with the opposite side, the right hip has a decreased range of motion noted in abduction, internal rotation, and flexion. Full laboratory workup was within normal limits. Okay, great. So we're having a lot of issues with right hip range of motion and significant pain with moving that right leg. Okay, so first thing, what are some of the things that are going to be on our differential? Sure, Ewing sarcoma. Sure, absolutely. Yeah. So that's definitely something that we need to keep in mind is anytime we have, bone pain in children, we have to think about our Ewing sarcoma. Any of those bone tumors can definitely be something to consider. Another thing to consider is, so for this particular boy, the pain began during a soccer game. So really, you want to keep your differential wide. So any sort of trauma to the hip could have resulted in maybe a minor fracture to that area. And then you also have to think of something like your slipped capital femoral epiphysis, right? So with slipped capital femoral epiphysis, we have a patient who has a painful limp or antalgic gait. That's what that means. And those children, those children typically tend to be a little bit more overweight, though, right? For slipped capital femoral epiphysis, those typically would be a child in the 90th percentile for weight. But they mentioned that this child's in the 50th, so probably not that, but we can keep it in our differential. And the last thing we should consider is that avascular necrosis of the femoral head are Legg-Calve-Perthes disease. Okay, so sort of keeping our differential wide there. What would be our next best step? This is your patient. You're on the service. What do you want to do next in terms of diagnosing what the problem is? X-ray. Excellent. I agree. So we do an X-ray. And what we see here is that on the right hip, we see a moth moth-eaten radiolucency, suggestive osteopenia of the femoral epiphysis, and a neck with shortened femoral epiphysis. Great. Bone scan of the lower deformities shows avascularity of the right femoral epiphysis. Okay, so taking a look at this x-ray, could you describe for me what you're seeing? What side is normal, what side's abnormal, and what does it look like? Yeah, I wish I had a way to have you be able to point things out for me. Um, so this is our right side. This is our left side. Which side looks abnormal? The left. Excellent. And what part? Like the shaft of the femur, the head of the femur? Yeah, right here on the head. Great. So comparing to the right side, and I kind of made a mistake here because in the question stem it describes a problem on the right side, and then this x-ray is on the left, so I need to correct that afterwards. But anyway, forgiving my small mistakes in making these questions, you can see... Yeah. Right. No, and I, this is really new to me. I usually never make mistakes, so this is really a first for me. I've never made a mistake before, so you're witnessing history. So we can see on the right side, the femoral head looks nice. This is a child, and so typically with your femoral head, it's not going to be closely connected to the neck of the femur, right? Because it still has to grow, and we want our child to grow nice and tall, so that has yet to develop. However, on the left side, you can see this is sort of that moth-eaten description that they're talking about. And really, the femoral head sort of looks like it's missing. Something's chewed it up and made it disappear. So what's our most likely diagnosis here? Right. Excellent, yes. So this is going to be our Legg-Calve-Perthes Disease, which is just avascular necrosis of the femoral head. They give it this really French name, which is unfortunate because all it is avascular necrosis, right? They could just call it that, but no, they have to call it LCPD. So LCPD, we look for that avascular necrosis, especially the capital femoral epiphysis, which is what we saw in the previous picture, where just the top is necrotic and broken down. This is going to be more common in boys, 4 to 10 years old. I wish that was really helpful. Unfortunately, a lot of these disorders we're going to be talking about are going to be more common in boys, and they're going to tend to be in this age range as well. So not as helpful as for some other things, but one thing to keep in mind. This is a self-limiting disease. So typically we're going to see these symptoms last for, under a year and a half. We just need to make sure that for that period that the child has this disorder, we are maintaining their normal femoral structure. We want to use different things such as bracing, bed rest, basically utilize any means possible to prevent the femur from shortening on that side. Okay. Typically, these are going to be asymptomatic at first. However, patients will then develop a painless limp. Okay. We're going to talk about painful limps, painless limps. And Legg-Calve-Perthes disease, it tends to be painless. If there is pain, it's typically in the groin or anterior thigh. In our question stem, our patient had a lot of tenderness to palpation in that area, and that patient had a lot of pain with external or abduction of the femur. Okay, so limited abduction, limited internal rotation, that's going to be typical. If you think about the part of the femur that's affected, it makes sense that it would be a little bit painful and a little bit limited to perform those maneuvers. Typically, this is going to be a unilateral disorder. If we have a patient that has full range of motion, just has a little bit of this limp, we can really just observe. We're going to do close observation, make sure that no pain develops, make sure that the child is able to maintain range of motion throughout the course of this disease, those 18 months, if that's how long it lasts. We're going to just sort of observe and watch. However, if there is a significant decrease in range of motion, we're going to consider bracing. Okay, so this is fully within the realm of step 2 CK. You need to be able to diagnose this particular disorder and know what to do next. And so kind of moving down this algorithm, the thing you're looking for is, does your child have range of motion? If there's range of motion, you can observe, send them home. If there's loss of range of motion, you need to brace them. Okay. So in terms of our prognosis, if it's a young patient under 5 with full range of motion and decreased femoral head involvement, a stable joint, that's going to be a great prognosis. And then as you take some of these things away, your child's a little bit older, maybe there's a little bit less range of motion, that's going to kind of affect the prognosis and make it a bit worse. Okay. So let's sort of look at some diagrams that will help us to understand this disorder. You can see in Legg-Calve-Perthes disease, what you have is just necrotic bone in the area of the head of the femur. This could be due to this obturator artery branch, which comes out of the pelvis. It could be due to some of these lateral femoral circumflex artery. At this point, we don't really know exactly what the cause is. It's idiopathic. We don't know what the exact cause is. We just know that this is sort of what happens is you start to get necrosis of this area. And your pelvic x-ray, you're going to have a look at that and see that moth-eaten look. There is really nothing else, Daphne, that looks like this. Okay? If you get this x-ray on a question stem, it's going to be like a gift from the gods. You're going to say, thank you so much. I know this disease, LCPD, choose bracing, choose observation, whatever you want to choose, and then move to the next question because there's nothing else that has that moth-eaten appearance. Okay? Great. And then so this picture I just included so you can have some idea of what bracing would involve. When I was making these slides, I was like, what exactly is bracing? Like, are we putting them in crutches? Are they going to be in a wheelchair? What is bracing? So these kids are going to be able to walk around fully, but this brace is going to ensure that this femur doesn't change its length in relation to the other femur. Okay? And so we may still have somewhat of a limp, but basically we're going to wait for the femoral head to regenerate over that 18-month period, and our kids should be okay. All right. So in terms of our differential of diagnosis for pediatric limp, this is from first aid. The mnemonic is starts hot. Okay? So all of the possible things. You have a kid that comes in with a limp. Before you look at any other information, here's all of your options. You could have a septic joint, right, where we have some sort of trauma to the joint, some bacteria is able to get in, and now we have a septic joint. You could have a tumor. Avascular necrosis is the A of starts hot. Rheumatoid arthritis or juvenile idiopathic arthritis, or juvenile inflammatory arthritis, tuberculosis, sickle cell disease, which would be a avascular necrosis as well, our slipped capital femoral epiphysis, Henoch-Schönlein purpura. So Henoch-Schönlein purpura, rather than being actually damaging the femur or the joint itself, this is really going to be more about just pain in the area of the leg leading to a limp. Okay, so Henoch-Schönlein purpura is a little bit different. Also look for abdominal pain in Henoch-Schönlein purpura, as well as the purpura on the flanks of the legs and everything else. Osteomyelitis and trauma. Okay, so this is a pretty useful mnemonic. If you're having trouble diagnosing when it comes to pediatric limps, this is an entire question class, right? And the question writers understand that students have trouble deciphering these and differentiating one from the other. So they're going to try and trick you. So being able to have this idea of a wide differential going into these questions is really going to be helpful, because then you can kind of just mark them off as you go along, and you're really making sure you consider all the options. Okie dokie. Any questions on LCPD? No? Okay. So asymptomatic, we may have a painless limp, limited abduction, internal rotation, and, full range of motion. We can just observe, otherwise brace. Great. So our next case here, a 23-year-old woman presents to her PCP with complaints of malaise, fever of 10 days duration, swelling in her ankles and knees. Okay, so what are we thinking here with sort of these constitutional symptoms? Rheumatoid arthritis. Good. We'll put that on the differential. Okay. How about one more for our differential? Sure. Okay. RA and SLE. That's definitely going to point us in the direction of something, right? Some kind of autoimmunity. It could also just generally be the flu, right? Malaise, a fever. You can have some, I guess not really swelling. It would be more arthralgias. Okay, so I like what you picked. We can stick with those. She's also been having chest pain, partially painful on inspiration and expiration. On questioning, this young woman states that she has always been healthy, has not had any sick contacts, has been in a monogamous relationship for 3 years. Her mother has Raynaud's disease. On examination, she's found to have no skin lesions or muscle tenderness. Her temperature, she is febrile. She has a pleural friction rub and significant effusions around her ankles, knees, and hands bilaterally. She has palpable cervical and inguinal lymph nodes. Radiography of her knees shows significant soft tissue swelling. All right, so our differential diagnosis, I still like rheumatoid arthritis. I still like lupus. Is there anything else you would want to add in here? Scleroderma, yeah. Let's throw that in there too. I'm glad you said that. So what sort of lab work would you want to do to be able to differentiate between those three disorders? Those all have markers, right? Okay. Good. Good. You're absolutely right. Mm-hmm. Anti-Smith. Okay. Anti-Smith, anti-double-stranded. Okay. Yep. Excellent. Great. So anti-Smith, anti-double-stranded DNA. I love that. What is this one for? Yes. Good. Good. And then so for rheumatoid arthritis, what marker can we use? Yeah, good. Rheumatoid factor. We'll stick with that. RF factor. That's a good sensitive test that's not very specific, right? So rheumatoid factor can be positive in a lot of other conditions, but it's usually positive in rheumatoid arthritis. So it's a good place to start. Excellent. Very good. I love that you can, really like pop these off of the top of your head. This is very helpful for getting to your answers on these questions. So excellent job. So we do our lab work. What we find, CBC shows 1100 or 11,000 for our white blood cell count. Hemoglobin's a little bit low. ESR is elevated, just like you said it would be. Rheumatoid factor is negative. Okay, so we can take out RA. Anti-nuclear antibody is positive. Anti-nuclear antibody, is this a helpful antibody test? Excellent. Yes, exactly. So we always look for this, but it doesn't really narrow our differential too much if we already know it's autoimmune. However, anti-double-stranded antibody is very helpful and is definitely going to point us in the right direction. Anti-Smith antibody happens to be negative. VDRL test is positive. What do we think of that? Yeah, lupus. Yeah, excellent. Yes, so in lupus, you can sometimes have this cardiolipin antibody. And that ends up giving you a false positive for syphilis. Great. Urinalysis, we see white cells, red cell cast, and proteinuria. So what do we think of this? Excellent. Yes, glomerulonephritis. Good. So most likely diagnosis is going to be SLE, which you correctly identified from the start. Very good. So SLE generally, it's just that chronic, multi-system, really affecting almost every organ of the body: skin, joints, kidneys, lungs, nervous system, the serous membranes, giving us that pleuritis like we had in our patient. Really any organ of the body can somehow have a manifestation of lupus. We will have remissions, chronic and acute relapses. 90% of cases are women, usually looking for a black female in their 20s or 30s. It's going to start out with some non-specific constitutional symptoms, really just kind of looking like a patient that has the flu. And then once you start to see other things that are abnormal, such as joint pain and swelling, that's bilateral, that's going to kind of put a red flag and say maybe this is not the flu, maybe it's something more serious. So let's look for that discoid rash. In this image here is where we see the discoid rash. Oral ulcers, photosensitivity, arthritis, that malar rash, this is step 2. They're not just going to give you a butterfly rash, right? We need to be able to identify some of this other clinical stuff. You can even have neurologic symptoms, so cerebritis, seizures, headache, renal disease, obviously, and serositis. Any serosal membrane can become inflamed, so that includes their pericardium, giving us a pericarditis, our pleura, giving us pleuritis. Okay. In terms of diagnosis, we need to meet 4 out of 11 criteria, with at least one of those being clinical and one of those being laboratory. So we're going to skip ahead really quick to the American College of Rheumatology criteria for diagnosis. And it has 11 criteria on it. Some of them are laboratory diagnoses, some of them are clinical things that we find. So the classic malar and discoid rashes, photosensitivity, oral ulcers, arthritis, serositis, so our pleuritis or pericarditis, some sort of kidney disorder, looking for red blood cells, protein in the urine, seizure, psychosis, and then looking for anemia, leukopenia, lymphopenia, thrombocytopenia. Any of those qualifies as one of our criteria. In terms of lab testing, we need to see that double-stranded DNA, anti-Smith or anti-phospholipid antibodies, and abnormal ANAs. So a positive ANA can be one of those criteria. So you really just need 4 of these to go ahead and diagnose SLE. So we said ANA is sensitive, not specific. Double-stranded DNA, anti-Smith are specific, but not as sensitive. Okay. One thing to keep in mind is while there is this, there's patients that get this idiopathic SLE. There's also patients that can get SLE secondary to taking certain types of drugs. And so in those patients, we look for antihistone antibodies. Okay. Great. So in terms of treatment, now that we're at step 2, this is really the bread and butter of what you're going to be asked about. So we're going to start off with NSAIDs. NSAIDs will decrease inflammation system-wide. When you talk about pleuritis or pericarditis, NSAIDs are a really great drug for decreasing that. Now, when you start having skin manifestations, musculoskeletal complaints that are not responding to NSAIDs, you can start using your anti-malarial drugs. And the first line for that, if you go to Up to Date or you go into your first aid book, you're going to see hydroxychloroquine as being one of the first go-to drugs for that. For advanced lupus, with a lot of significant systemic involvement, sort of going stepwise here in terms of treatment, once you have used hydroxychloroquine, it's not as effective, you can start using immunosuppressive drugs. Cyclophosphamide, azathioprine will be your go-tos. Okay. Systemic corticosteroids, we really just want to use that for the acute exacerbation, and then we're going to taper those steroids as soon as the exacerbation is over. Okay. Great. Okay. Any questions on lupus? No? Okay, great. So just sort of a review of all the things we talked about. And excellent. So shooting for those 250, 260 scores. What sort of drugs are associated with inducing lupus? When we talk about drug-induced lupus, what are some of our usual suspects? There's 7 of them, but if you just can give me 2 or 3, I will be happy and leave you alone. Okay, good. Uh-huh. Yeah, I had a mnemonic for this on step 1 too, and I don't remember it, but maybe we can make one together. Yeah. So one of them is a drug that we use to treat tuberculosis. Mm-hmm. Excellent. Yes. Isoniazid is one of the ones they very commonly ask about in relation to causing lupus. Another one is blood pressure medication that quickly drops blood pressure, which is our hydralazine, right? Another one would be, I'll just give you the list here. So procainamide, quinidine. Quinidine is sort of one of those tricky ones too, because quinidine is a anti-malarial drug. And we talked before about how we can use anti-malarial drugs in treatment with lupus. So don't get confused about that, sort of a tricky thing there. Chlorpromazine, hydralazine, isoniazid, methyl-dopa, and penicillamine. Okay, so the mnemonic that I put here when I was making this slide is PQ-CHIMP. If that works for you, please take this and run with it. If not, I'm sure there's a lot better mnemonics out there than PQ-CHIMP. But yeah, so procainamide, blood, one of the antiarrhythmics, quinidine, anti-malarial, and yeah, so great. Any questions on this? Okay, and so what antibody are we going to look for with this drug-induced lupus? Wonderful. Okay, case number 3. We have a 35-year-old man referred to a orthopedic surgeon with our severe back pain. Great. Radiating to his left leg. Okay, so for back pain, especially lower back pain, what are the things that pop to your mind in terms of a differential? Sure. Especially with that radiation, I like sciatica, yep. Yes, ankylosing spondylitis, yes. Trauma, sure. That's a great differential to start. Herniated disc, great. So he has not been able to play in his weekly basketball game since the pain began 5 weeks ago. During the past 2 weeks, now the pain is increasing in severity. He can only sit for 20 minutes before the shooting pain becomes intolerable. He claims he's had back pain before, but has never been this severe, has always been well controlled with NSAIDs. Currently, he reports getting no relief with NSAIDs. The pain is affecting his ability to sleep, wakes up from the pain every 1 to 2 hours, denies any recent back injury, infection, weight loss, or changes of appetite. Okay, so this is important as well, obviously ruling out any tumor or anything like that, tuberculosis, things like that. The patient appears to have an athletic build, stands throughout the office visit. On physical exam, raising the patient's left leg 30 degrees above the horizontal plane reproduces the pain. Does not occur with the right leg. The patient has no focal lower extremity weakness, but he does have an absent Achilles tendon reflex on the left. Okay. So, differential diagnosis. What are some of the things that you're really concerned about at this point? Or if you feel like you know the diagnosis, that's fine too. Yeah, ankylosing spondylitis. Okay, good. And next best step. Good. Absolutely. Okay, good. So you do the x-ray and you don't really see anything noticeable in x-ray. And then you do your entire panel for ankylosing spondylitis. It comes back negative, and the patient is still having pain. What other imaging options are available for you? Excellent, good. So which is better for seeing a herniated disc, CT or MRI? MRI, excellent, good. So we get an MRI and we see the following. What do you think? Yes, very good. Yep, and it's just pushing right there on the spinal cord. Okay, very good. So herniated disc is very, very common cause of lower back pain. What we have here is a protrusion of the nucleus pulposus, which is the middle part of that spongy material that protects our spinal cord and allows it to have a little bit of bounce. The nucleus pulposus is in the middle, and it pushes through the annulus fibrosus of an intervertebral disc into the area of the spinal cord. Okay, so that protrusion is what's causing the pain here. Typically, the pathogenesis is that your patient will have an initial event, some sort of trauma that causes weakening of the annulus fibrosus. Okay, so we have some weakening of the annulus fibrosis. Now, over the next week, month, 6 months, what's going to happen is this nucleus pulposus is slowly going to start pushing out through that weakened area. Okay, and so when you get a slip, it's called slip disc, right? It's usually not an instant thing where you herniate the disc right away and it's the same level of pain for the next 6 weeks. Typically, you have that weakening, which is typically associated with a little bit of pain, and patients say, okay, I need to take it easy. And then over the following period, as this bit of intervertebral disc is pushing out and starting to impinge the spinal cord, symptoms are going to get worse and worse. So you'll have patients that first have pain, and then they start to have paresthesias, loss of sensation. They have weakened motor reflexes, like our patient with the absent Achilles reflex. That's going to develop later as this is pressing more and more on the spinal cord. So what we look for is a sudden onset of severe electricity-like lower back pain, preceded by several months of aching, discogenic pain. Okay, so this is kind of getting into sort of that weakening, progressing to the actual herniated disc. This is common in middle-aged and older men, exacerbated by increased intra-abdominal pressure, Valsalva, and this is associated with sciatica. So when you talk about the diagnosis of sciatica, typically it's due to a herniated lumbar disc. That's going to be your most common cause of sciatica. Okay. We can also look for paresthesias, muscle weakness, atrophy, contractions, and spasms. As we go through these different differential diagnoses of lower back pain, what you're going to see is typically you'll have weakness, or you'll have pain, or you'll have paresthesias, but typically you don't have all three of those together. And so herniated lumbar disc is sort of a special case where you get that weakness and you get pain and you get paresthesias. Okay. A passive straight leg raise increases pain. As soon as you see that, I want you to think about a herniated disc. Okay. Straight leg raise is herniated disc. That's what you're looking for. If you end up with a large midline herniation, that can cause cauda equina syndrome. Okay, so what is cauda equina syndrome, and why is it such a big deal? Mm-hmm. 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 Compression, yep. Mm-hmm. Good. So, cauda equina syndrome is sort of the next step of severity, because not only are you now having this paralysis, like you mentioned before, you're also going to start seeing urinary retention as this herniation is pressing on some of the splanchnic and pelvic parasympathetic nerves, right? So seeing loss of inability to urinate, loss of that rectal tone. Those are some of the things we look for with cauda equina syndrome. Cauda equina syndrome is a surgical emergency. Okay, this patient urgently needs to be taken to the OR for decompression, or they may never get some of those sensations back. Okay, so we're going to obtain an ESR just like you recommended. Okay, you told me we want to rule out ankylosing spondylitis. I love that. So obtaining that ESR will let us know, okay, is there some sort of inflammatory, infectious cause here? We're also going to get that plain radiograph x-ray if other causes of back pain are suspected. Great. Order a stat MRI for cauda equina syndrome. So this is kind of getting into making the right choice on CK. If you are seeing a patient that looks like a herniated disc, but then they also have urinary retention, you're going to skip the abdominal x-ray and go straight for MRI. Okay? All right, great. Order an MRI if symptoms are refractive to conservative management, and then you can obviously see that disc herniation beautifully on MRI. So our treatment here, NSAIDs on scheduled doses to help with the pain, physical therapy, local heat will actually lead to resolution within a month in most cases, 80%. That's pretty good. So just making sure that this patient's getting a lot of physical therapy, not putting increased stress on their lower back and increasing that protrusion. That's really the important thing here. Okay. Epidural or nerve block may be beneficial. And obviously, if we have those rapidly evolving neurologic deficits, we need to do a discectomy, remove that disc, and typically they'll take the disc out and they'll fill that space with some sort of cement. Okay. All right. So in terms of our differential of diagnosis of back pain, this is a really beautiful chart from UWorld, which I'm probably not supposed to have. Okay. Please do not call the FBI on me. But I just love this chart because it's, if you cover up this side with a box or something, I'll give you this PDF, cover up this side with a box and then be able to nail all of these clinical cues. And it's really going to help you in solving these questions on step 2. You know as well as I do that they love asking about this, right? So degenerative osteoarthritis, it's going to be positional and relieved with rest. That was not the case for our patient. He was being woken up at night. Okay, so it can't be osteoarthritis, right? Radiculopathy, this is our gentleman. We have the pain radiating to the leg, sensory plus motor findings, and that positive straight leg test. That's money, okay? That is your diagnosis. Pick your answer and move to the next question, okay? Spinal stenosis, this is our patient who is the grocery cart old man, right? So he has pain on standing, but it's relieved by spinal flexion. So when he's standing and he has his hands on the grocery cart and he's kind of like bracing himself on that grocery cart, that makes the pain go away. So I always imagine that, with spinal stenosis is that old man pushing a grocery cart. Whenever you have them describing something like that, think of a spinal stenosis where we have a little bit of bone that's impinging on one side of the spinal cord as it leaves, or one spinal nerve as it leaves the spinal cord. Okay. Spondylosis, so a young man, HLA-B27. This is going to be relieved with exercise. Okay, so as they use their back more, it's going to feel better. Nothing else really is described that way, right? This is the only one that has relieved with exercise, and that's because it's inflammatory. So that makes sense. Spinal Mets, constant pain, worse at night, not responsive to position changes. The only thing that I can really say about spinal Mets is that in terms of treatment strategies and pain relief, for these patients, you would want to do a fentanyl patch rather than doing some sort of IV or PO pain reliever. And the idea there is because these patients are in constant pain, there's nothing that really relieves it. With a fentanyl patch, you're going to have that slow, steady release of medication throughout the day and night. Okay. Last, our vertebral osteomyelitis. Here, they're going to talk about focal tenderness when you press on the spine. A lot of these other conditions, there will be tenderness maybe around the area and the muscles around the area, but when you have that point tenderness, you really think about a bacterial infection there. Okay. All right. Excellent. Okay. Any questions on lower back pain? No? Okay, great. Alrighty. Case number 4. 66-year-old woman comes to the rheumatologist's office complaining of muscle aching, weakness in the upper arms and thighs, and severe fatigue. Okay, so what are we thinking here? Dermatomyositis. Good. Mm-hmm. Uh-huh. Yep, polymyalgia, I like it. Rheumatica. Polymyalgia. Fibromyalgia. Good. Good. That's exactly where I want you to be in terms of differential for this case. I think you're pretty good on musculoskeletal. I don't know why you said this is one of your weak spots. I mean, in terms of building a differential, you're right there. So it seems like you're in a good spot. But anyway, so let's continue here. She also notes an unintentional weight loss of 2.3 pounds over the past 6 months. Patient symptoms are most severe in the morning. Denies any history of trauma, arthritis, denies fevers, headache, jaw claudication. Okay. On physical exam, Patient is tender to palpation along her shoulder girdle bilaterally, as well as her trunk. Has a normal neuromuscular exam, no obvious signs of inflammation in any of her joints. Okay, and so in terms of your diagnosis, considering this history, is there anything that you can take out for sure? For your dermatomyositis, polymyalgia, fibromyalgia, of those three, would you like to eliminate any of those? Wonderful. Yeah. Polymyositis. Yeah, they both fall in that inflammatory, picture. So great. So we'll take both of those out. We're left with fibromyalgia rheumatica and fibromyalgia. Okay. So in between those two, those are the two that they're going to try and trick you on. Okay. And so you need to have a really clear picture in your mind about how those patients look. Okay, what kind of patient gets fibromyalgia? What are their complaints? What kind of patient gets polymyalgia? What are their complaints? Okay, so that's what we're going to look on together. What are we going to see in labs? So if we do our ANA, we do our rheumatoid factor, we look for autoantibodies, are those going to come back positive, negative? Would those be positive or negative in general? Good, excellent. Okay, good. So we go ahead and do the lab findings. We see white blood cell count normal, red blood cell count normal, ESR elevated, like you told me, CRP elevated, rheumatoid factor negative, ANA negative, CPK is normal. So this kind of eliminates our dermatomyositis, right? Dermatomyositis, you usually see elevated CPK. Rheumatoid factor eliminates RA, ANA eliminates a whole bunch of other stuff. And so our most likely diagnosis with all these considerations is going to be polymyalgia rheumatica. Okay, it has that rheumatica thing in there, so we can still think about ESR being elevated. But other than that, there's not a lot of inflammatory markers that we see. Okay, our ANAs, CPK, all these inflammatory markers are usually negative, except for that ESR elevation. Okay, so this is our polymyalgia rheumatica. Treatment for polymyalgia rheumatica, because it is still within the realm of inflammatory diseases, what would you want to give as a treatment? Sorry. NSAIDs, okay. Yep, NSAIDs are good. And also corticosteroids. Low-dose corticosteroids. Okay, great. So polymyalgia rheumatica, clinical syndrome, severe aching and stiffness in the neck, shoulder girdle, pelvic girdle. So in terms of differentiating this from fibromyalgia, those are the two that they're going to try and trick you on. For these types of patients, these patients are going to have pinpoint tenderness when you press on areas in their neck, shoulder girdle, and pelvic girdle. There's actually in terms of diagnosis, the way you diagnose this is you find 14 points of tenderness on this patient's body, and they have to have something like 6 or 8 of those being positive, and that's how you diagnose polymyalgia rheumatica. In terms of fibromyalgia, the way that I really think about fibromyalgia is I think of a patient with a fibrofog. Okay, fibrofog is that description of just sort of feeling dull, tired, confused, thoughts moving slowly. That's your fibrofog patient. Polymyalgia rheumatica, those patients don't really report anything like that. Fibromyalgia, they're more just sort of lackadaisical. They feel like they don't have energy. They feel weakness. It's really hard to treat. Those types of patients, you typically also see other things like inflammatory bowel syndrome, where there's no marker to diagnose inflammatory bowel syndrome, right? It's sort of there's a psychological aspect to it. Same thing with fibromyalgia. There's a large psychological aspect to it, and in terms of treatment, you actually can use SSRIs for fibromyalgia, and that's a psych drug, so sort of an interesting thing there. Here, relatively prevalent, 1%, so that's a solid number. Rarely affects patients under 50. There is a strong association here with temporal arteritis, so we need to rule out temporal arteritis. In any patient you have polymyalgia rheumatica, you got to rule that out. So how do we rule out temporal arteritis? No, no, you do. Yeah, you're absolutely right. Yeah, so you actually do a biopsy of the temporal artery to rule it out. Yeah, yeah, I nailed it. And I know that sounds extreme, but because temporal arteritis can be so severe, leading to blindness in patients, we really need to make sure that that's not there. And so you do go ahead and go for the biopsy. Okay. Excellent. So symptoms, we get a subacute or chronic symmetric aching and morning stiffness in the shoulders, hips, neck, and torso, those areas that I showed you on the image. Fever, malaise, and weight loss. This weight loss thing is also pretty specific for polymyalgia rheumatica, not something you see in fibromyalgia. You may even see weight gain in fibromyalgia, but these patients, you have weight loss. Okay. Weakness is generally not appreciated on exam. They have full strength. They just sort of have stiffness and aching. And I know some of these definitions can kind of start blurring together when you talk about stiffness versus weakness. But it's really, you really just have to look for the specific words, right? In terms of diagnosing. So you can hear things like difficulty getting out of a chair, lifting arms above the head, getting dressed in the morning, brushing their hair. There's a little bit of overlap there with myasthenia gravis, right? And so, but myasthenia gravis looks a lot different. So it's something to keep in mind. Yeah, so definitely you can. Yeah, definitely, because you have difficulty with doing a lot of these same behaviors. Some of the large muscles get inflamed in polymyositis, right? And so you definitely have some of those same things. Yes, yes, I agree. I think that part of that picture would involve weakness, though, and so so here. I'm trying to think what the best ways to differentiate it would be. When you press on the muscles of patients with polymyositis, that actually elicits a lot of pain and tenderness, pressing on the muscles themselves, okay, in polymyositis. You can also see those skin findings in dermatomyositis. So, okay, excellent. So in terms of diagnosis, we can look for elevated ESR, and we may even see some anemia. Treatment is just going to be low-dose corticosteroids, so 20 milligrams of prednisone, for a month or so should typically resolve a lot of these symptoms. We don't want to leave patients on corticosteroids too long, right? But otherwise, that's a pretty good treatment. Alrighty? All right. Yes. Yes. Mm-hmm. Mm-hmm. So in terms of polymyositis, the primary part of the picture is going to be weakness. That's the biggest part of the of the picture with polymyositis. With polymyalgia rheumatica, that is going to cause symmetric pain in the muscles. Okay, so that's why you're looking for those painful areas. With polymyositis, it's really the big part of the picture is just weakness. And so, there is a lot of overlap, but it's like, what is the primary thing that the patient is complaining of? When it's this pain, aching, especially in the shoulder girdle, pelvic girdle, though that should be really red flagging you for polymyalgia rheumatica, versus polymyositis is really more of the weakness type picture. Okay. Okay. Great. All right. So, moving on to our next case here. Great. So, 65-year-old woman referred to the orthopedic surgeon by her primary care for evaluation of right knee pain. Just 10 years ago, she was a competitive marathon runner, but over the past 5 years, the aches and pains in her joints have begun to limit her physical activity. She reports she can only walk about a half mile before the pain in her knee forces her to stop and rest. On examination, her right knee has a moderate effusion, but is not warm or erythematous. She has decreased range of motion in her right knee relative to her left. So, differential diagnosis for this patient. Osteoarthritis, okay, I like it. Yeah, yeah, right. RA should definitely be lower because it's the one joint. I love that you said that. Good. Next best step. Good. Good blood work and x-ray. And so on our x-ray, we see this. Okay. What are you thinking now? Are you still like OA, or are you thinking something else? Yeah, right? Okay. So in terms of things we look for on OA, this really image really captures a lot of them. So what you're looking for is narrowing of the knee joint. And typically that narrowing is going to be on the medial side. If you think about the way we walk and where the pressure is kind of transmitted, it's more on the medial rather than lateral side. And so if we look at our tibia here, this is our fibula, you can imagine this is going to be the medial side and this is the lateral side. And so you see that it's much more narrow in the medial side. Great. You're going to look for these little osteophytes, bone growths into that space. You can also look for subchondral bone cysts, which are a bit harder to see, to be honest with you, but a lot of times they will be described for you. Subchondral bone cysts, just little areas of under the cartilage where you have cystic formation in the bone. Okay, and then seeing this white blood cell count normal and a normal ESR definitely rules out RA, and so we are going to have osteoarthritis, like you said, right off the bat. Great, so chronic, non-inflammatory degenerative process, mechanical wear and tear, it's affecting those hips, knees, and spine. We're going to see this worse on one side or only present on one side, okay, versus RA, which is symmetrical, which you told me before, and a really helpful way to diagnose this particular one. Older folks are going to tend to be more affected. They have more wear and tear, so that makes sense. On x-ray, we look for joint space loss or narrowing, that's sclerosis or cysts. Bony osteophytes can really cause a lot of pain as that process continues and be an indication for needing to go in there and clear out the knee joint. In general, however, our treatment is going to be conservative. So, number one, pain management with acetaminophen, NSAIDs, just sort of decrease the amount of pain our patients are having. We also want to prevent progression. So anything that makes the pain worse, that's the body telling the patient that that particular, whatever they're doing is causing more osteoarthritis. So avoid that, right? Going up lots of stairs, whatever it happens to be, trying to avoid that. There's this question of intra-articular steroids, and so because this is not really an inflammatory process, there's some question of why would you even want to use steroids in the first place. But in reality, a lot of times steroids can help with the pain, and sort of that analgesia of the area can be helpful. But in general, when you're asked on step 2 CK, the go-to drug is going to be one of those over-the-counter NSAIDs for pain management. Okay. For patients that are refractory to all this, you can go and do an arthroplasty where you replace the knee joint. Okay. All right, great. Okay, and so I actually have to run today. I'm sorry I can't stay to do another case, but we will be meeting again tomorrow morning, right? 7 a.m. and we'll